call myself a VIP patient, not because I'm very important, but because I have been engaging with the medical system since I was like basically a year and a half old. And so through that, I've seen the good, the wonderful, the bad, the ugly, all of the above.
Hey, podcast listeners. If you're a healthcare leader in technology, operations, or policy, or if you've ever found yourself lost as a patient in a complex system, the other side of the chart is for you. I'm Dr. Jill Goldenberg, a physician, clinical informaticist, and leader in value-based care and quality. I've spent my career at the intersection of people, process, and technology, working to build systems to improve how care is delivered and experienced. This podcast is where we make that personal. Together, we'll talk with patients, clinicians, healthcare leaders, system designers, and innovators, not just about what healthcare is, but what it should be. Before we dive into AI, payment models, or documentation, we're starting where healthcare actually begins, with the patient. In this premiere episode, you'll hear more from Dalia, a lawyer, a mom, a wife, a friend, a daughter, a sister, and so much more. And someone who has spent more of her life inside the healthcare system than outside of it. Diagnosed with her first tumor as a toddler and with multiple cancers since, Dalia knows medicine not just as a patient, but as a super user. The story you're about to hear is complex. At times, it's heartbreaking and often deeply frustrating. But it's also filled with moments of compassion, innovation, and care that actually worked. Dalia reminds us what's at stake when care becomes a maze and what's possible when it becomes personal. She's lived what most of us design from a distance, and what she sees from the other side of the chart is essential for anyone building, delivering, or reimagining healthcare today. So let's get into it. Dalia, I can't thank you enough for joining us today for our very first episode of The Other Side of the Chart. Can you share with our audience a little bit about yourself?
Well, a little bit about me. I am a mom of two young children, and a lawyer, and uh, you know, just living my life. Unfortunately, that's included dealing with what has become essentially chronic illness, even though it's not technically defined that way. So, in a nutshell, cancer has become a chronic condition for me, even though it's really not what typically is a chronic condition. I have had cancer 4 times. I'm 48 years old. My first tumor was removed when I was a year and a half old. So, um, but, you know, cancer has been a major part of my life. My mom died of cancer. My aunt died of cancer. I never met my grandfather on my mother's side. Um, and then as an adult, when I was 31 years old, I was diagnosed with breast cancer, then colon cancer, and now pancreatic cancer. All of them separate, discrete cancers, thankfully, all caught pretty early. And so I've managed to basically be someone who's lived a long time with cancer, but that has also involved a lot of specialized care, a lot of screening, a lot of scanning. And it wasn't until I was pregnant with my daughter that I did additional genetic testing. And that's when they found another mutation. It's called TP53. At that point in time, it was a mutation of unknown significance. So there wasn't enough data to know whether it was a cause or not of cancer. Then a few years later, I got a phone call that it had been upgraded to pathogenic. And overnight, I was diagnosed with what's called Li-Fraumeni syndrome, which is essentially a name to indicate that you have a disposition for basically all types of cancer. So unlike BRCA, which really causes breast and in some cases breast and ovarian cancer, TP53, the mutation that can result in you getting basically any kind of cancer. And so because of that, I became eligible for annual screenings and head to toe screenings, and that has been life saving for me.
Hmm. Hey, audience, before we move forward, I think we all just need to acknowledge that that's a lot to carry, and not just the medical challenges, but the family history and everything that comes with it. Daya, before we go further into the healthcare experience side of things, I want to pause to get to know you a little more. And not just as a patient, but really the person behind the chart. I'm going to call this a non clinical vitals check. I mean, vitals are, after all, how we start most of our medical visits. So, Dahlia, can you share with us something your medical record would never capture?
This sounds really dumb, but I can be really silly and lighthearted. I feel like my chart presents me as a very serious person with very serious problems. And a really good example is, those mental health check questionnaires that they pretty much give
Mhm.
you
Yeah, it's called
at
a
every,
PHQ2 and a PHQ9. Yeah.
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 So they're both making sure you feel safe at home, which I do. And also, how's your mental health? And it's often like, are you sleeping? Are you this? And like, if I answer those honestly, I probably need to be checked into a psych ward because I'm under a lot of stress because I'm being diagnosed with cancer. So I filled it out honestly at one of my visits, and the nurse practitioner was like, based on this, I feel like I should refer you to a social worker, but you seem okay. And I was just like, well, yeah, they're really unfair questions for someone who just got diagnosed with pancreatic cancer. I am not sleeping well. I'm very worried. I think I'm going to die. Like, these are
Right.
all very real feelings. It doesn't mean I'm having a mental breakdown. I'm having very normal human feelings about that. And she started laughing. And I was just like, but there's this like, again, the data doesn't reflect the person,
Person. Yeah.
and it's impossible to do that, right? But I don't know, maybe little things in the chart like husband makes bad jokes. Things like
Yeah. I love that. And for the record, I can confirm the bad jokes. I've heard a few myself. But seriously, what you just said captures so much of what this podcast is about. There's this whole human story behind the numbers and the scores, like the PHQ-9 that you just described. You're so totally spot on that the data just doesn't fully reflect the person. So, with that in mind, let's talk about the system itself because you've spent more time navigating it than most. Can you walk us through what your entanglement with healthcare has felt like? And again, not just as a patient, but as a person.
I mean, I'll be the first person to say I don't like engaging with the healthcare system. Um, I'm the type of person who hates to take pills. I'm the type of person who doesn't like to take medicines of any kind. I prefer not to go to doctors, and I was always that way long before. And I think part of that is when I was a little girl, I had to go quarterly to get blood drawn because I was missing an adrenal gland. And all I remember is how horrible it was
Mm.
to get blood drawn. So I just remember crying and being traumatized by all these blood tests, which lasted until I was about 12 years old when they were like, you are stable. You don't need to continue doing this. So I think I'm guessing from that experience, I just, have never really been a fan of going to the doctor. That said, I trust doctors, I trust science. I'm definitely um, will engage if I need to, and will go to the doctor. And so, but like many people who engage with the healthcare system, a lot of times no one believes you, right? When I got breast cancer, I went to my primary care doctor because I felt something, and she just kind of brushed it off, and was like, "You're too young to have breast cancer. You can probably get a scan in like 6 weeks to 2 months, and we'll figure that out." And I went home and I didn't feel good about this. I felt like, especially, both my mom and my aunt had died of cancer. I went on WebMD and they had a checklist of like what is likely breast cancer versus not. And
Hmm.
I checked every box and I was like,
Yeah.
oh God, I'm
Yeah.
probably cancer. So I called my gynecologist, went in, and she was like, okay, I'm sending you today. So if you think about the disconnect between the two
Right.
doctors, right? And
Yeah.
I was just like, oh God, I'm going to die. This is terrible.
Yeah.
I went, and I mean, from the ultrasound, they were like, they were already assuming cancer. And it turned out that I had what they thought was a 5 centimeter tumor, which would automatically kick it into stage 3. It turned out that's not all of the tumor was cancerous yet. So they downgraded it to stage 2 once we got full pathology and everything like that. But yeah, it was aggressive, fast growing, showed up like all of a sudden. And I'm very lucky that I checked myself and then advocated for myself and got a second opinion.
Hmm.
But had I waited 2 months to get a scan, I might have been in a very different situation with a very different prognosis.
That's such a powerful reminder of how critical it is to be heard and how much it can matter when you trust your gut. Even when it's hard to do that, that advocacy likely changed the course of your life. I know you know that. Um, but I also imagine it's kind of exhausting to always have to advocate so fiercely. I know you're going to touch on some bright spots, but maybe before we move on to that, can you talk to us about any other times when the system really kind of let you down? Maybe some of those more difficult experiences when care kind of felt impersonal or dismissive.
So, some of my most negative experiences have been, frankly, with really young doctors or residents,
Okay.
and in the emergency environment or in the hospital system, where, number one, people are very busy, they're saving lives. You can't underestimate that. Totally reasonable. During breast cancer, one time I had to go to the hospital to the ER because I was having an unfortunate symptom. So I went to the ER. I ended up being admitted into the hospital to a bed. It was like 2 in the morning. I was finally like, okay, I can go to sleep. And they decided that I needed to have surgery to get my appendix out. And I was just like, hold on. Like, I was told I should not have surgeries while I'm doing chemo because
Sure.
of the potential for infection and things like that. And by the way, I did not come in for appendicitis. I have no symptoms of appendicitis. They had just done a CAT scan and it looked like, I guess, my appendix was inflamed or something that indicated that. I was just like, I'm okay with you doing this if you talk to my oncologist. Like, I don't know how to decide this. And they're like, well, can you call her? I was like, you want me to wake up a doctor in the middle of the night, or you, a doctor, can call her, or we can wait till tomorrow since I have no symptoms of,
Right.
and my oncologist, this is true to her form, had given me her cell phone number. And she's like, call me if anything weird happens. So I called her and she was like, what? And like immediately called the doctor, and they decided to try antibiotics first rather than put me into surgery and risk infection because my blood counts were low and like I had a higher chance of infection. And so then because I wasn't having surgery, the nurse came in. She's like, I'm really sorry. I was like, what? They're like, we may need to move you to a different floor. And I was just like, why? And they're like, they're kind of fighting about whose patient you are. And I was like,
Gosh.
what? The next morning, the antibiotics worked, whatever was happening resolved. And then by the end of the day, they're like, well, you can go. And I was like, but I never got the tests that I needed to. That is why I came in to the hospital for. And they're like, just follow up with your oncologist. When the resident came in, she's like, I'm really sorry it took me so long. I was dealing with sick people.
Oh gosh.
And I wanted to punch her in the face.
Sure.
I didn't. Obviously, I was like, I just rolled my eyes. From a patient perspective, it was unacceptable. I should not be moved at 3 in the morning. There's no reason for it. And, we're not, you know, to the patient, we don't care what floor we're on. We don't care. We care that we're getting the care that we need and we're being treated as human beings. That's like one of the worst experiences I've had, but I don't think it's completely atypical. Like, I think it
Right.
happens, especially when people are tired and busy.
Gosh, that must have been so upsetting and frustrating, and certainly not the kind of care any of us would hope for. It's really hard to hear how often you weren't seen or truly listened to. But I also know that that's not the whole story, that you have had moments and people and places where the care felt far more personal and more human. Can you tell the audience about some of those experiences where you did really, in fact, feel heard and seen?
So when I got breast cancer, I will say my medical team was excellent. I got access to the best doctors. I was really fortunate
Mhm.
to be connected to a medical oncologist. So there's the surgical oncologist who do the surgeries, and there's the medical oncologist who do the chemo and all the medications and things like that. So when you're 31 years old, there's not a lot of you who are
Right.
grappling with this, and there's not a huge network. And the concerns that a 31-year-old woman would have would not be the same as a 60, 70, 80-year-old woman. There's just a lot of different considerations, including, can I have kids? Can I,
Right.
things like that, that just are not an issue when you're an older woman. The treatments are also slightly different for younger women than older women. And so she kind of created not only a practice centered around that, but also a support community around that. And I call her the godmother of young women centered oncology. My medical team, her nurse, the way she set up her treatment, she didn't have it at the hospital. She had her own little office that she decorated in a really nice, cozy way. Her nurse was this incredible, smart woman who uh, was so compassionate and so helpful. And she's like, I'm guessing you're the type of person who loses weight when she's stressed. I was like, yeah. She's like, you forget to eat? I was like, yes. And she's like, yeah, I'm going to give you a cookbook of things that you can prepare in advance that will also help treat your symptoms. It was so thoughtful and so personal and so not medical,
Yeah.
but addressing very medical issues that were about to happen to me. They were incredible. They met me where I was at. At one point, I had a complete nervous breakdown, and I'm not exaggerating. I really had a nervous breakdown. That when I went in to see my oncologist, she's like, I think we need to stop your treatment right now. And I was just like, but you said it's a 50% chance in reduction of recurrence and this and that. And she's like, okay.
Mhm.
And the first thing she did was hug me before anything. And she hugged me. She's like, hug me this way so you can feel my heartbeat. And I was like, and I just melted
Sure.
and started crying. And she's like, you just realizing or acknowledging that you've had cancer. Because a lot of times when you're going in treatment, you go into fighter mode, you don't think about it. This was after I was finished chemo. And that's when oftentimes people start dealing with the emotional side of what they've gone through. And then she sat me down and she's like, I think we need to stop the hormonal treatments. And I was just like, but you said, and this is really important, and I really want to live, and this and that. And she goes, you're a very analytical person, Dalia. I'm going to take your pathology report and walk through the presentation I do for my medical students, and showed me her PowerPoint presentation with my pathology report next to it and walked me through why this was an okay decision. And it was just it showed me how medical treatment is as much an art as it is science. And she really treated me as a human being. And she's like, you need to feel your age. You need to, like, you shouldn't be going through menopause right now. We kicked you into menopause. It's made you go bonkers. Like, you don't need that right now. And we can revisit it. But this is not the driver of your cancer. The driver of your cancer is this, and we are treating that, and we are giving you the medicine for that. And that level of personal touch, I think I'm very, very fortunate with. And that's been true quite a bit through my, not every time, but through my journey, and the level of treatment that I've gotten.
Yeah.
So,
Yeah. Yeah. What I'm hearing is how powerful it is when care feels deeply personal, when you're seen not just as a diagnosis, having breast cancer, but actually as a whole person. And that, at its core is what the other side of the chart is all about. So much of healthcare today is really built on looking at populations, on outcomes, on metrics. And listen, all those things matter, but when it comes down to it, care happens really one person at a time. And it sounds to me in those moments when the care teams and that culture really met you where you were, when they brought forth empathy, that's when the system really worked best for you. Yeah. So let's switch gears. You've mentioned to me before that engaging with healthcare has felt different in recent years, especially with the widespread use of electronic health records. That's actually the focus of my next episode with Dr. Kevin Larson, where we dig into the documentation that makes up the medical record. So I'd love to hear your perspective as a patient on the receiving end of what we now call open notes. That's this movement where we actually give patients access to their records, and not just access, but we do so in real time. So we give them access to both notes and results as they become finalized. So tell the audience your thoughts, um, given the lived patient experience that you have.
I find it super empowering. It also has reduced logistical challenges and fees, for instance, in transferring records from one place to
Sure.
another and having to call an office that then has to look for your record, and it could take weeks. I can now download it, send it directly, or if my network of doctors share systems, they can just log on and look for it, and I can make sure that all the appropriate consents are there. I can say some of the information can be overwhelming. And as a patient, I've learned not to immediately look at everything or try to analyze it myself, and be a little bit patient, because, this is where Googling and all that can become a little bit dangerous. And, like, you can think, not, I mean, it turns out I often do have cancer, but not everything is cancer. But if you Google, you will always have cancer. Like, it's always an option. If you look at basically any website, there's always the potential for cancer, right? It's rarely that, or understanding why blood levels might be a little bit up or down or this and that, and, like, not freaking out. So I have learned to kind of take all that information with a grain of salt and wait until I can talk to my physician before jumping to conclusions. The other side of this, you often get results, like official results, faster, which I think is wonderful because the waiting game, especially when you're dealing with life threatening diagnoses, is excruciating. Us patients in the cancer community, we call it scanxiety. It is not insignificant. It is real. It keeps you up at night. It keeps your families up at night. And for someone like me who gets scanned all the time, to wait weeks to understand what's going on is not a great experience. So the fact that I can log on and check it, and I could see for other people it'd be really overwhelming. But more often than not, I find it very empowering. Also, so that you can, if you need a second opinion or you need to talk to somebody else, that you have access. It's about you. It's your body. You should have access to this information. It shouldn't be a black box, right? So.
Yeah. Dalia, thank you for sharing your take on electronic records, especially your perspective on how empowering it is when patients truly have access to their own information. That kind of access isn't just practical, it's representative of what we mean by the other side of the chart, a system that values the patient voice, their autonomy, and their full participation and collaboration in care. Well, let's flip to your recent cancer center experience. So, as you know, I'll tell the audience, I had the honor of joining you on a recent visit to monitor your recent cancer diagnosis. And I'd love you to share a little bit about that experience. I just got to see a snippet of it. I thought the experience you had was phenomenal, and I was very impressed. But I'd love you to share with the audience because you shared with me a lot of sort of anecdotes about even just the building and the people and the process. And I think there are lessons to be learned that we could apply elsewhere in healthcare.
Um, yeah, happy to. So to catch people up, I am now battling metastatic pancreatic cancer, and the traditional treatments have not worked. So I have been very fortunate to get access to a clinical trial that's being run out of a number of facilities across the country, but where I'm getting my treatments at Dana Farber Cancer Institute in Boston. And they basically took over a couple of floors of this old shopping mall and repurposed it for this medical clinic. Having been to a number of different medical centers, just the design and the flow of how they manage you as a patient is extremely impressive. It also reduces the amount of time in waiting rooms and just sitting there. It reduces it because they have a workflow attached to how patients are moved throughout their office. They start out with labs, then they move to getting their vitals checked in a different place, and then you move to where you see the doctor. And then if you're getting treatment or an infusion, you go to the infusion center, and it's like a big circle on two floors. And then they also have radiology as well. So everything is right there. They also, which I think some patients might actually find this creepy, but actually appreciated it, is they put trackers on their patients. This, although seems really big brotherish, it allows patients to move around the building and the nurses to be able to find you if they need you. So let's say you're spending all day in an infusion center and you want to walk around, or you want to go get some food in the cafeteria and not just sit in a chair. As long as you're capable and with your connections or this and that, you can do that because they can find you if they need to find you. Whereas if they can't do that, then you have to sit there and you're kind of stuck, and you have to be at the whim of the people who are treating you, and that can like feel like you're taking away your autonomy. So okay, originally, as a privacy attorney, I was not too keen on these little trackers, but I've grown to actually appreciate them. And it's only in the hospital. It's only when you're there. So it's a super impressive, like you can tell that they have learned from decades and decades and decades of experience on how to manage patient workflow. And the net, back to your original point of, that personal touch, it creates more space for that. And it creates more space for that personal engagement because the workflows are so scaled and so, you know, thought through and thoughtful that the doctors and the nurses, they can just focus on what they're doing and not be thinking about our patients going to the right place. So, and it's a give or take, but, you know, I, for me, I thought it just brings a little bit more humanity into a very clinical setting. So,
Yeah. Yeah. I was way impressed with the flow that you just described, the people along the way. It was a really warm, bright, kind of
yeah,
happy environment.
I think they go to great lengths to find people. And I think oncology, because people are in clinic so much, is a area of medicine where they probably do the best job. And you have some of the most compassionate people because choosing to go into oncology, you're choosing to often not succeed,
Yeah. Yeah.
right? And so, oncologists and their teams tend to be very compassionate in general.
Yeah. Well, that's a good segue to some lessons that I hope you can help us with, maybe for the system as a whole, but maybe also just for other clinicians listening. So, Talia, if you could build something, whether it be a product, a service, maybe a whole new system that kind of captured the best parts that you've told us about in terms of your cancer journey, and if you could apply them to other areas of care, because as we said, I think oncology, not universally so, but I think does have a leg up on the rest of healthcare delivery. What would that product or service look like?
There's a few places for major improvement, particularly in really large medical systems. One is scheduling. I have been on hold for an hour trying to get an appointment or not being able to get an appointment, but I've been told I need to get an appointment. I've been referred by a physician. I've been done, and like, you know, how does that work? How can we improve that? I don't know that I have the solutions because some of it is just bandwidth, hours of the day, and things like that. But um, to not even be able to get someone on the phone or a message returned, to streamline systems to make it easier for the people on the other side to navigate it, and also, allow, I think there's some improvements that could be lessons learned from other industries. And definitely some places do better than others. Um, I also feel like if there's a disconnect between the administration and the physicians, that tends to create the worst outcomes because the person at the front desk who's just answering phones may not understand what is a priority and what is not. And they just have like they're just following a game plan, a playbook. But if there's an actual connection with someone on the medical care side to facilitate that, then it seems to work smoother. That's been my impression and my experience. Other thing is design actually matters. And I never would have thought about that. But how you create spaces and how you move people really can impact the experience. If I were to create a system, my most recent job, I've been working in government supporting state agencies on all their technology, law, and policy issues. And something that we were working on was a system like the medical records system, but that could also integrate all the social determinants of care. So food security, access to social workers, access to state benefits, and things like that, and create a system where the medical side and the public health side could talk to the human services side. And that's the system that I would build. And then also from a process point, obviously, I am a lawyer, so I think about legal process and there's streamlining to be done there. Like the consent issue is a real issue. You need to get it. How we get it is overwrought, overcomplicated, doesn't help patients, and it doesn't help the system at all. I would standardize them, I would simplify them. It should be like bullet points, simple sentences. It should be at a third grade reading level. And I think that would empower the entire system on both sides of the chart to understand what's going on. So those are the systems that I would build.
Love it.
And I'm a big, I really liked the Blue Button initiative that really gave all of the records and to the patient. And that's, I think it's now transformed into electronic health records. But I really do believe like the champion of their own healthcare should be the person, should be the patient. And the medical system should be facilitating that care.
As we wrap up today's first episode, I just want to extend a huge thank you again to Dalia. I want to thank her for her candor, her clarity, and most importantly, her courage. What she shared with us today is more than just her personal story. It is a lens we all need to look through more often. Too much of healthcare still happens without hearing the voices of people like Dalia, people living with the complexity who don't just want to survive the system, but want to be seen by it. Dalia, you reminded us that the chart may hold the medical facts, but it doesn't hold the full story. At the end of the day, care is human. And if we're designing systems, technology, and policy without patients like you at the table, then we're just not doing it right. Thank you for joining us on this very first episode of The Other Side of the Chart. I hope you'll stick around with us for episode 2, where we talk with Dr. Kevin Larson, a national leader in clinical innovation and health policy. We'll explore what it means to build a system that supports transparency, trust, and real patient agency. This is The Other Side of the Chart, stories and insights for those building the future of healthcare from the inside out. We'll see you next time. The Other Side of the Chart is a production of G-Berg Productions, produced, hosted, and sound editing by Dr. Jill Goldenberg. Music by Relaxing Motivational Corporate by Fretbound. From Free Music Archive, licensed under Creative Commons Attribution 4.0.